Good afternoon, members and guests. I'd like to call the Finance, Ways and Means Committee to order. It is Tuesday, February 21st. Madam Clerk, would you please call the roll?
Representatives Barrett, Boyd, Campbell, Camper, Cochran, Crawford, Faison, Freeman, Gant, Garrett, Hawk, Hicks, Kiesling, Lamberth, Love, Lynn, McKenzie, Miller, Moon, Parkinson, Shaw, Sparks, Whitson, Williams, Zachary, Vice Chairman Baum, Chair Lady Hazelwood. Madam Chair, you have a quorum.
Thank you, Madam Clerk. Are there any personal orders or announcements before we get underway? Well, I do have one. I think it is incumbent upon this committee to wish one of our members a happy birthday today. We will do you a big favor and not sing, but Scotty Campbell, happy birthday.
Madam Chair.
All right, Representative Campbell, you're recognized. I did make a mistake and call your name.
Thank you, Madam Chair. I didn't recognize that as a mistake, but I was just wondering if I could make a motion to roll that a year.
You can roll it for 10, but it doesn't change the aging process. Sorry. Any other personal orders or announcements? All right, today we have several budget hearings scheduled. We have one bill on our calendar, and that bill, item number 1, House Bill 48, has been asked to be rolled by its sponsor, Leader Lambert. So without objection, Leader Lambert.
Thank you, Madam Chairman. And like Representative Campbell, my name was called. So just very briefly, the Senate put on a slightly different amendment than what we have. And so, Madam Chairman, I appreciate you rolling that 1 week. I just want to make sure the posture is the same in the House and the Senate. So that's the only reason committee for the roll. Thank you, Madam Chairman.
All right, thank you for the explanation. Without objection, we will roll House Bill 48 1 week. We are now going without objection out of session and go directly to our budget hearings. The first group that we'll have in front of us today, the Department of Health. So we would ask them to be coming up. Commissioner and your team, if you would please introduce yourself and those sharing the table space with you.
Thank you, Madam Chair. Appreciate the opportunity to come before you today. I'm Ralph Alvarado, Commissioner of Health. I'll let my team introduce themselves.
John Webb, Deputy Commissioner for Operations.
Elizabeth Foy, the Chief of Staff.
Welcome.
Thank you very much. Appreciate the opportunity to come and present some of our budget requests for the Department of Health. Wanted to start first, this is an opening kind of remarks. I don't need to remind anyone of the crucial work that's done by our health departments across the state of Tennessee and the safety net providers to improve the health and the vitality of our constituents and the lives of the people here in Tennessee. And if you haven't had an opportunity to visit your health departments locally anytime recently, I'd invite you all to visit your local health departments to see what they do. Some of the most committed people you'll ever meet work in our health departments locally. I've had a chance to tour several of them already, leave impressed every time. And I would encourage you to do so as well. I thought I'd start first today with kind of an introductory slide. People often wonder, what does the Department of Health do? And the Department of Health utilizes the strategic framework really to guide services provided to the people of Tennessee. And we have a two-pronged approach. One of them obviously is for prevention and the other is for access. Some of the examples of things we do in prevention is working with our county health councils to outline strategic health needs at the local level through county health assessments. We work with the Tennessee Strong program to provide youth an opportunity to plan, implement, and participate in tobacco education and prevention events across the state, and also work on things like evidence-based home visiting programs that assist children and families in all 95 counties preventing adverse childhood experiences. In terms of access, we also know that we've obviously run a lot of our primary care clinics through a lot of our health departments as well. We continue to try to improve clinical efficiencies and the quality of care for patients through a variety of means, including revamping electronic health records, expanding dental access, working with external partners like the Rural Health Task Force, Dental Task Force to continue to implement programs to ensure access to people in rural areas of the state. And also, as a part of improving services provided to people, the department's modernizing methods of service delivery, including offering telehealth care options throughout the state as well. Just as a quick budget overview, the department's fiscal year 2024 budget request totals about $870.1 million. And we continue to try to promote the work of public health within our strategic priorities. But I thought I'd cover today predominantly the cost increases, which I know was of interest to the committee. And so I wanted to go through these one by one, if you allow, Madam Chair. The first cost increase you're going to see there is for Tennessee Strong Families. It's a total proposal cost of $6.6 million in state funding, $1 million in non-recurring funds. This is part of the administration's initiative to improve health outcomes for mothers and children. It's a multi-pronged approach to help counteract factors contributing to infant and maternal mortality. There's four main proposals or portions of the proposal. The first one is the expansion of CHANT, which is a community health access and navigation in Tennessee. That's $1.3 million. It basically takes existing TDAH care coordination programs for young families to medical, behavioral, and social services. It's currently funded by Maternal Child Health Title V funding, and it also support from TennCare. We also have $2.3 million in the perinatal telehealth infrastructure. 2/3 of Tennessee counties don't have a delivering hospital. And there's a lot of high-risk telehealth systems that exist to a small degree in some regions like UT Chattanooga and UT Memphis. This is an opportunity to build a much larger statewide system. States like Arkansas have implemented similar programs and demonstrated significant improvements in access and patient care. This includes $2 million for 3 to 5 institutional grants and about $0.5 to $1 million each as seed funding. We also have $2 million in this item that are investments in perinatal care centers and EMS training. We know that a lot of these perinatal centers were established in the 1970s. I think we have a total of 7 throughout the state. These provide 24/7 clinical support for hospitals in their regions to assure that higher risk pregnancies are delivered at the appropriate level of facility care. The funding has been flat since 2016, despite large population growth and higher volumes due to closing of rural birth facilities. So the funding would update materials, equipment, as well as training for EMS, emergency transport, and delivery staff in rural areas. And then also in that $6.6 million is a $1 million doula pilot program. Doulas provide guidance and support to the mothers of a newborn baby during pregnancy and also during the birthing process and also during the postpartum period. The literature is promising for improved birth outcomes, so a pilot has been created. It'll support grants to replicate freestanding community-based doula pilot programs statewide or practice integration models. Those are from $125,000 to $250,000 each. Cost increase number 2 is year 2 of 5 of the expanding dental services pilot project. This was obviously a large 5-year project that was a total of $94 million. It invests over $66 million in the expansion of the dental professional pipeline for both dentists and hygienists. And in addition to investments in educational infrastructure, it also provides $20 million for optimizing dental care for the uninsured populations. And lastly, it includes over $8 million in recruiting and incentivizing dentists to serve in rural and underserved areas. I have another slide later on that'll cover a bit of information regarding some of the success we've had already. But in this $16 million, $11 million is being directed to higher education institutions to provide continued support of expanding dental service classes and the creation of remote clinics to improve rural outreach. And $5 million will support prosthodontic programs, dental programs for seniors, and the recruitment incentives as well. Items number 3 and 4, I'm going to lump together. This is for the healthcare safety net. It converts a lot of non-recurring funds to recurring and implement the quality improvement incentive program. Right now in FY22, the uninsured adult healthcare safety net program provided primary care and care coordination in 93 counties in Tennessee for approximately 373,000 primary care encounters to adults ages 19 to 64 and provided around 100,000 dental procedures. The additional funding will help support an increase of 100,000 medical encounters and 8,000 dental encounters. And this will set a constituent service reimbursement rate for providers. The QIIP, which is the Improvement Incentive Program, is going to improve the quality of care and patient outcomes through measurable clinical outcomes for providers through a quality incentive payment program. Almost like we see now in private insurance, it'll do the same thing for a lot of these clinics. We've been working with the Tennessee Charitable Care Network and also the Tennessee Primary Care Association in trying to help establish that program. Cost increase number 5 is for the victims of crime vital records. This is a proposal. It's a project done in conjunction with the district attorneys and the Office of Criminal Justice Programs to assist families and victims of crimes in securing vital certificates at no cost. The department would essentially institute a fee waiver for individuals that would qualify under the program, and all recipients of fee waivers would be confirmed through coordination with OCJP. Cost increase number 6 is for naloxone purchasing. This is about $750,000 in non-recurring funds from the opioid settlement funds. This would purchase and distribute naloxone to locations within the 5 designated HIAs, or the high impact areas in the state. The funding supports the purchase of about 12,600 doses of naloxone and could be administered to 6,300 people. And the purchase and distribution of these drugs will bolster existing efforts in combating the opioid crisis. I'll just go over the quick statistics. In 2021, 3,814 all drug overdose deaths in the state of Tennessee. 2020, we had 7,063 non-fatal overdoses that required inpatient stays. So these doses will definitely help in hopefully lowering those numbers. Cost increase number 7 is school-based dental positions. This is at $722,200 in recurring interdepartmental funds from TennCare. This would increase staffing that would allow the department to expand these dental services to approximately 4,000 underserved children throughout the state. Each hygienist right now under this staffing proposal could see 1,350 children annually, and the proposed number of staff would be 8 full-time staff, 5 dental assistants, and 3 dental hygienists. I think total we had 160,508 dental sealant numbers applied to children throughout the state, and the number of children that received kind of silver diamine fluoride was 4,248. Cost increase number 8 is procurement positions. This recognizes the additional federal funds to provide long-term support to the Department of Health Contract Office to handle increased contract and grant volume and to improve turnaround times. It'll allow 4 full-time staff with the $314,000 that are allocated there. Next slide, we have cost increase number 9. This is for newborn screening position. This will allow 1 full-time nurse to be hired in this regard, and it'll create a newborn screening long-term follow-up program. We've got one of the best newborn screening programs in the country. It's the envy of a lot of states, and this will allow data to be collected on the disorders diagnosed from the panel. We often hear about kids being screened. The question becomes when they actually get diagnosed with a problem, what about the follow-up and how do we handle that data? That'll be derived from the long-term follow-up that can be used to determine the best outcomes using the most optimal treatments for related disorders for future diagnosed patients. And it also lends itself to the consistency of treatment of disorders to ensure equitable treatment of diagnosed patients, identify variants of significant leading to disease to help aid in treatment decisions, and evaluate and improve the newborn screening efficacy for early detection and early treatment resulting in better outcomes. Cost increase number 10 is for state public health lab positions. This is $295,300 in recurring state funds. It would provide recurring state funds for the expansion of the department's core genomic sequencing program. In addition, the additional positions would provide improved oversight and management for the expanded NBS program I just mentioned earlier, and also support for the expanded lab web portal, which will be for cost increase number 11. And that is $375,000 total, $295,000 of that going to recurring state funds, $80,000 for non-recurring state funds. This would expand the current lab web portal and the Oz system to assist in the requesting and reporting of test results from our state lab. It kind of modernizes a lot of that. It's something that they've been requesting for a long time, and it will allow a lot of hospitals and others to be able to look at results, order tests more easily. Cost increase number 12 is for $600,000 dedicated to recurring dedicated state funds for board. It would come from board fees, but it's going to help increase to allow equity increases to make the Department of Health staff salaries more, and it'll help us provide salary increases to retain critical employees. Slide number 5 is a supplemental request of $16 million. This is for electronic health records. Currently, the department is replacing its electronic health records throughout a lot of our primary care clinics and our health departments. It's been much needed. The system they're using is from an old VA medical center system that's pretty antiquated. Everyone's really excited about it. And I know when I've had a chance to meet folks, they're looking forward to being able to have something that's more modern to be used. As has happened to a lot of projects during the pandemic, the costs have been increased with this as we've contacted the vendor. And as a result, we've had discussions with FNA, and the full funding for the project contract was included in the supplemental request. I thought I'd cover also, there's been some requests, I think, from the committee regarding ARPA funds and where we stand on those. I thought I'd give a little bit of a quick synopsis on where we stand on those projects. The total amount, this would total is $825 million. And the department has several proposals that were approved through this process. The first one I want to cover is the new state public health laboratory. You probably have heard a little bit of update regarding that. That's $200 million. The old facility is an old tuberculosis hospital that is kind of met its time. It looks nice from the outside, but on the inside has a lot of work and a lot of needs. And really, we have a rather good state laboratory that offers a lot of services to other states as well. And this is going to be required for the full implementation of the facility. We have $129 million towards local health department infrastructure. Many of our county health departments are looking forward to these funds as well. I think we've got 17 counties that are going to receive brand new facilities for health departments, and all the others are going to get some amount of money to help with upgrading their facilities. That can be used, anything to help with roofing repairs, new generators, helping with flooring repairs, just redoing the front windows to make it more accessible to patients who come there for care. This is going to require a local match of the lesser between 25% of the total project costs or 10% of the local government's ARPA direct allocation. And it's also part of that is $92.6 million is going towards that. 19.5 is going to the construction of one new regional health office located in the South Central region as well. And the remainder of the funds that aren't allocated yet will serve as contingents for construction overruns and administrative costs. $120 million is being used for healthcare staffing assistance. $70 million is going towards hospital staffing assistance and $50 million towards nursing home staffing. This will allow hospitals to claim $259,200 per month in staffing costs as a result of increased staffing needed to address COVID-19 patients. The nursing home portion of this project, I think, began launching in late January, if I'm not mistaken. So some checks started to roll out to help a lot of our nursing homes. And again, they can help claim COVID-19 expenses up to a predetermined cap based on facility bed counts. This is of crucial importance. Not every state allowed these funds to be used for that. So I commend the department for having gotten this in the past. We also have $230 million going towards healthcare resiliency program. This is a great program that's going to look to expand physical hospital capacity, enhance care delivery at healthcare facilities statewide. About $145 million of that are going towards predominantly hospitals and nursing homes. There's a 50-50 match process. It's basically allowing a bigger healthcare pie to be done to allow for more beds, higher acuity beds, better ability to respond in emergencies and pandemics. The remainder of the funds, about $75 million, is going towards practice transformation. And this is to allow integrated services, mobile medicine, if you will, alternative care models of medicine. And it's going to provide broader availability for applications to ensure some innovation in the healthcare space. The dental project was something I think was of interest to the committee as well for the past. Wanted to go over some of the success we've had with this in year one. $11.9 million were allocated. Part of this money went towards grants to dental schools. So $4.7 million went to the University of Tennessee and $2 million towards Meharry. The funding supported the expansion of class sizes at each dental school. UT increased its dental class size from 100 to 110, and next year's class size will be 120. Meharry's went from 62 to 75, and they've increased their resident slots from 8 to 12. The additional support is allowing Meharry to assist the department in reopening dental clinics in Smith and Putnam counties, and also Wilson and Montgomery sites to be staffed by Meharry faculty and residents later this year. We've also allocated $4 million of that in support for the Smile on 65 Plus and Smile 180 programs. These are to help people that are over the age of 65 who need dental care that may not qualify for dental care under other programs, to assist them with dental needs, and also provides restorative and prosthodontic services for uninsured patients statewide. We also provided some funds for the dental loan repayment program. An average dentist comes out of training with about $300,000 in loans. We provided $100,000 per year and require a year of service after each $100,000 is paid. So far, the department has recruited 2 dentists through our coordinated loan repayment strategy, and we're hoping for much more in the near future. And also, we have a lot of community dental training, which works with a lot of external partners to establish workforce development opportunities for dental staff in underserved areas. The next little bit is on our healthcare safety net, which is always obviously of importance for a lot of folks who represent their areas. And currently the department receives $24.1 million in recurring state funds to support the healthcare safety net in cooperation with the General Assembly. And the Lee administration has more than doubled the available funds for those programs. And we thank you very much for that investment. Currently, like I mentioned earlier, 373,000 primary care encounters, 100,000 dental encounters, 224,000 served in care coordination. Across the state, there are more than 200 primary care and dental safety net clinics serving 93 Tennessee counties. 64 of those are community and faith-based providers. 138 are federally qualified health clinics. 49 are dental providers. And again, like I mentioned earlier, we're working closely with the Tennessee Charitable Care Network and the Tennessee Primary Care Association in trying to develop a kind of the next phase in patient outcomes, trying to benchmark and use metrics for quality improvement in clinic participation in the funds that are being used. And then on slide 9 is kind of our health disparities grant. The department's working with a broad network of providers to assist underserved populations in mitigating the impacts of COVID-19 across Tennessee. We have 4 strategies, which are to expand existing and or develop new mitigation and prevention resources and services. So we're trying to train a lot of community health workers in rural and urban communities on ways to mitigate the transmission of COVID, and also using our faith-based and community organizations and working together to reach populations to assist in mitigating strategies. We're also trying to improve our data collection and reporting. We're trying to provide training for faith-based and community partners in this regard, and also expanding our data collection efforts with vulnerable populations. And we're trying to expand our training and apprentice programs that supports the recruitment and retention of entry-level healthcare workers in rural areas as well. So we're trying to build, leverage, and expand our infrastructure support. We're also trying to mobilize partners and collaborators to create and expand partnerships with community and faith-based organizations that deliver culturally and linguistically appropriate materials and training for a lot of our vulnerable populations across the state to address COVID-19 related health disparities. That's as quickly as I can go, Madam Chair. I know the request was for 5 minutes. There was no way I could cover a lot of that material in that span of time, but I tried to go as quickly as I could to cover some of the highlights. And if we're open for any questions, if the committee has any.
Thank you. And if you had gone any more quickly, we couldn't have understood you anyway.
That's exactly right.
At least I'll speak for myself. My Southern brain sometimes takes a little time to catch up with that rapid speech, but we do appreciate the brevity. I will say 5 minutes is sometimes a negotiating tool for us, because if we say 5, then we might actually get people who do it in 10 versus 30. So it's all relative, but we thank you for a very high level, but you touched on a lot of things that this committee has interest in. But I do have folks who have questions who want to dig down a little further, starting with Chairman Hicks.
Thank you, Chair Lady. Commissioner, thank you for being here, you and your staff. Thank you for what you do. I want to go back to the dental services pilot program and a couple questions there. Outside of UT Knoxville and Meharry College of Dentistry, is the Department of Health seeking to partner with other dental schools in Tennessee with this pilot?
I'm not aware that we have. I mean, those are the current 2 schools that we've partnered with in the future. So again, I'm fairly new to a lot of this in terms of other discussions that may have occurred in the past. So I'm going to let our Deputy Commissioner kind of answer that question.
Representative Hicks, we had a non-recurring grant with LMU to kind of help establish their dental program. That was not in our original pilot request, but it was a special appropriation, I'd say, in the bill last year. And so that would be the other institution that we have a contractual relationship with.
That was a trick question. I represent LMU, so I was just wanting to get that on record.
Yes, sir.
How are you going to measure outcomes for this pilot program?
Well, I think ultimately what we want to do for part of this is to try to recruit more providers into some of our rural areas. We're trying to educate more dentists, to have more dentists available. Obviously, some of this is also to expose them to rural healthcare and rural dentistry. I think sometimes a lot of our residents, where they become in dentistry, don't have an opportunity to do that. I think if they can experience it, it's going to give an opportunity to have some more exposure and to attract some of them. Obviously, when you have loan forgiveness programs, we've already attracted 2 dentists just in year 1. There's an opportunity to help fill some more of those operatories that we have available throughout a lot of our health departments. I've had a chance to tour several in the northwestern part of the state. They're beautiful facilities. They're as good as any dentist I've ever been to. And it's just a matter of having folks that are willing to serve in those. So I think we're going to see success by having more people serving in those capacities. And that's how we're going to judge if the pilot is working.
And, for me, I guess the way that I hope it does work, and I look forward to it working. And I hope as we get into, I guess, year 2, and then we eventually get to year 5, I'm hoping we see so much success that we're able to actually expand that a couple more years, because dentistry is much needed across our state, certainly up in Northeast Tennessee. So I certainly look forward to supporting this initiative. Thank you very much, Commissioner.
Thank you, Representative.
Chairman Hawk, you're recognized.
Thank you, Madam Chair. Commissioner, welcome. Glad to have you here.
Thank you.
Expanding on the dental aspect, let's talk a little about the school-based dental service positions that we've got. We've got $722,200 for 8 new positions. Is that TennCare funding? And if it is TennCare funding, will we be able to go outside the parameter of children on TennCare?
It is it's a recurring interdepartmental funds from TennCare, so it is from that. And as far as going beyond that, I'm not certain. I know it's kind of a statewide school-based prevention program. I think we've been involved with over 20 years, working with TennCare and the department together. So this has been a long time collaboration addressing a lot of the dental needs. It works predominantly for children kindergarten through 8th grade. And basically kids who attend public schools who I think have more than 50% or more of the student population participating in the school lunch programs. 35,000 kids have been screened with this. The success rates, anywhere you go, any state that's offered this program shows markedly reduced caries rates and cavities rates in these children. And so the key is if you can catch a lot of these kids early, help prevent a lot of that, you're going to be able to preserve a lot more teeth as they go forward. And teaching a lot of these kids education and good habits. And a lot of the dental hygienists are working in this regard. I've had a chance to talk to some of them as well. They love their jobs. They like doing this, and I think they feel like they have an impact with it. But in terms of the money does come from TennCare, and so I think there'll be an opportunity to be able to track a lot of this. And again, it's money well spent, really, in terms of reducing cavities.
Chairman Hawk, did you have follow-up?
I do. Could we define how those 8 positions will be distributed across the state? Is there and I think you mentioned that some of the positions are hygienists, some are assistants. If you could go over that one more time and how they might be distributed to our grand divisions.
There's 5 dental assistants, 3 dental hygienists, and as far as distribution in the state, I'll defer to my deputy commissioner. here.
We can get you a distribution. We don't have that in front of us.
Okay, Chairman Hawk, did you have anything else? And I do have a follow-up, and maybe you answered it with Chairman Hawk's question, but if this program is going into a school in my district, a Title I school, for instance, can any child in that school access the program, or do they have to be covered by TennCare in order to be a part of the program?
You want to, yeah.
I'm gonna have to get back to you on that particular item. I know the schools that we target generally are outlined by the parameters Commissioner spoke of, but in terms of eligibility per individual child, I can follow up with the committee on that.
Just like to know how that is determined,
Yes,
what
ma'am.
their patient population would be.
Yes, ma'am.
Chairman Hawk?
Thank you, Madam Chair, and getting hand signals from the audience, knowing that the TennCare is our next presentation. I think there's a nod and a wink that it may be available to everybody. Okay. So I'll answer my own question that I asked, as well as the chair ladies, that it looks like there will be an opportunity for all students to participate in that. Thank you, Madam Chair.
Thank you. And a few years ago, I had the opportunity to serve on a local board associated with Children's Hospital, where I'm from, and we had a mobile dental clinic, and it was incredible. I think people don't realize the illness that can come from poor dental hygiene, and actually a child who died from a situation that, had it been addressed proactively, would not, it was something that you would think would have been a simple problem to fix, but it wasn't addressed, and it led to death. So it is incredibly important. We appreciate the work that's being done in that regard. Chairman Boyd, you're next on my list.
Thank you, Madam Chair, Lady Commissioner. Appreciate you coming today. Just a quick question. According to y'all's drug overdose data dashboard, fatal drug overdose deaths have gone up tremendously from 2017 to 2021, actually from 500 to 2,500. We know in the governor's budget, he has provided a non-recurring appropriation of $750,000 for naloxone. I want to make sure I say that right, from the opioid settlement funds. And so can you tell us how many kits can be purchased with this funding, and will they be distributed evenly to health departments or just specific areas?
Yeah, it's going to be 12,600 total doses, and that can be administered to 6,300 individuals total. That's the amount of purchase, and they're going to be distributed to help bolster that. It can be done across the state, and it's going to be, again, I think the numbers that I had is the number of non-fatal overdoses in 2020 were 18,733. So this is going to help treat a lot of those folks. Obviously, we've lost a lot of people during the pandemic, in particular, with a lot of there was less interaction for a lot of folks. We saw a spike. I think that was true nationally. So it's happened not only here in Tennessee, but everywhere. And so we're very conscious of that. This is going to give us an opportunity to be able to administer those doses. They should be available across the state, but it's a total of 12,600 total doses.
Thank you. And Commissioner, is it effective on all drug overdoses, or just certain types?
So for Narcan, it's typically for opiates or any kind of a opiate type of overdose. If somebody's unresponsive, I think most of our EMS folks are trained to administer this. just because the presumption is that that's the case. But it's typically most useful on opioids. So if people are having an opioid, fentanyl, any kind of a narcotic, that typically falls into that category.
Thank you, Madam Chair.
Chairman Zachary.
Thank you, Madam Chair, Commissioner. Good afternoon. We have a supplemental appropriation in the budget for $16 million for the electronic health records. Can you just provide us some detail regarding that $16 million, how it's going to be utilized, please, sir?
Certainly. Let me find my notes on that. So typically what's happened is we've implemented, again, as I was mentioning earlier, but very quickly. That's our slide 5. There it is. So we're replacing the electronic health record. Again, we have a very antiquated system that it's used. The Veterans Administration Medical Center has typically offered one back in the early 2000s. We've been using a very similar model currently. A lot of our personnel are having to go into 4 different systems at times to check somebody in, to look for background information, to put it in, and it's just very cumbersome to be able to keep a lot of records. And so the program was rolled out. It started back in March of 2021, and during that planning phase of the project, the department earmarked funding from federal COVID grants to support the full cost of the EHR replacement at that time. As the department entered into the contract with the vendor, grant management staff were informed that the earmarked federal funds would not support the full cost of the entire project. And so the department then sought to try to self-fund the project through one-time budget savings. However, we had some discussions with F&A, and then the full funding for the project was included in the supplemental request that we have before you now.
Great. Thank you. Thank you, Madam Chair.
Thank you.
Chairman Williams.
Thank you. Thank you, Commissioner, for coming. I just had a couple questions on vacant positions. I think, sorry, over here, odd looking fellow. I noticed in your budget documents from last year that you had 302 vacant positions last year. I think you recognized 53 of those vacant positions were held for more or unfilled for more than a year. I also noticed that this year's budget requested, I think, another 17 full-time positions. I guess the question would be, if we have 300 and some odd positions that are unfilled, 53 of those which have been unfilled for over a year, why the need for additional 17 positions? Why not just eliminate those 50 positions or reassign some of the 53 for the additional 17? I don't know if maybe you could speak to that as it relates to those positions and the new ones as well.
Commissioner Webb.
Representative Williams, you are correct. I actually had us run the report at the beginning of February, so we're a little worse off. We got 308 vacant positions, but still 50. But we've got 51 now that are vacant for 12 months or longer. When I looked at those vacancies, about 25 of those are clinical, and those have always been our hard to recruit positions. Doctors, nurses, those have always been very difficult for us to do. So we're hesitant to abolish those types of positions. We have 7 dental positions that are vacant. You've heard Commissioner mention our recruiting efforts in that area. And so those would be some that we would be hesitant to abolish. And then there's some lab positions. We've had a hard time competing with the private sector given the COVID pandemic, but we think at some point folks will come back and work for our labs. So that really leaves us about 16 positions that are administrative. Your point's well taken that we could take a look at those kinds of things, but these are all positions of need in general. With the new market salary adjustment that was just implemented by DOHR, we're hopeful that we could get a little bit of time to see if those new market ranges would help us attract candidates for those long-term positions.
Okay. Thank you.
And I guess the sort of obvious question to follow that is, what is the impact of those vacant positions been on the operations of your department?
It puts a strain on things, obviously. We kind of figure out ways to make things work. And that's not always the best way to approach things. And we get stretched a little thin at times, but we definitely would like to try to recruit and retain more folks and make our lives a little easier.
Chairman Baum.
Thank you, Madam Chair. Commissioner, I've got a question about some capital projects. Your department has received several $100 million in FSAG funding for a new state public health lab and some capital improvements for some local health departments. I was just wondering if you could give us an update on the progress of those projects.
Should be happy to. So as I mentioned earlier, the $200 million for the state lab was a project that replaced the current state lab located in the RS Gas Complex. And again, if you've been out there to have a chance to tour the lab, if you haven't, again, I would invite anyone who want to come out and see the good work that's being done there and the broad amount of work that's being done. It impacts a lot of departments. And again, they bring in a lot of work from several other states as well. But the department engaged a consultant earlier in the year to outline and define the needs of a future facility. And this is an FRF property, so the Department of General Services is required to implement the full construction of the facility. And they're working with DGS right now to finalize the early stages of contracting and design work. So that is moving forward. In terms of the other project that you had mentioned was some different things that we're getting from FSAG. You said in terms of improvement for local health departments and infrastructure. It's a total is $129 million. It's, again, I mentioned earlier, comprised of two major components. The first one is $92.6 million. That's to local governments to help build, renovate, and upgrade local health department facilities statewide. The grants are available to 89 rural counties with the minimum project amount of being about $450,000. And that grant program requires a local match of the lesser between 25% of the total project costs or 10% of the local government's ARPA direct allocation. And grants for this project have started working through the approval process already. I believe there's 17 counties that are going to get brand new facilities. And several of those, as I mentioned, I've had a chance to tour several. They're excited to get it just for basic roofs that are leaking, signage that they need for their facilities, flooring that's damaged and they need to replace, just entrance for patients when they come in to be able to, a lot of them to be able to meet them where they need. Some have to require to be seated down and to be able to fill out paperwork to get a lot of that done. So, and there's a second component to that also. It's dedicated to the construction of a new regional health office kind of in the South Central region. That's for a total of $19.5 million as well. And again, that's going through DGS as well to be able to implement that. And there's the leftover funds out of that $129 million will go towards administrative costs and overruns in construction, which we know has become unfortunately commonplace with a lot of construction issues since the pandemic's been done.
Okay, thank you.
To follow up on that, do you have any idea at this point what those overruns might be and what the actual cost? Are you confident that you're going to be able to fund these with the $129 million, and then you have the $200 million for another facility that's going to be a construction project? So how confident are we that the amount of money that's been allocated is going to actually bring these projects to fruition?
I would probably answer saying that we're hopeful that it will be that way. It's always difficult to determine how much that is, but we have, I believe if you add up, again, 19.5 and the 92.6 should put us around $112.1 million. So, out of 129, that's about $17 million we have allocated for overruns. And again, just with worry, we have that in reserve. We're hoping we don't have to use it, but if we do, we've got it available, and we're hopeful to get it done.
And what is the timeline on these brick and mortar structures? When are they expected to be open for business?
That would depend on the local needs as far as getting a lot of those done. It also depends on a lot of our local government officials. So again, that match is required. So if those have been matched and things are ready, I think they can start the process. A lot of them are making plans already. I'm not aware of any, Deputy Commissioner, if you've got any already rolling.
We're shooting for the end of 2026 because of the FSAG
Right.
funding availability. So that's when we would hope to have everything up and running by then.
And does that include the public health lab?
Yes, ma'am.
Right. Chairman Faison.
Thank you, Madam Chair. Commissioner, staff, very good to see y'all. Quick question about where we're at with the AIDS funding. We've seen a lot of news stories since Governor Lee decided to forego the federal money that's coming in. Seems like to me there's probably going to be some state funds. Is there a plan moving forward that is going to come out soon that we kind of know where we're at with the AIDS funding and how Tennessee is going to be involved and how we're going to engage the local communities with it?
Sure. So thank you for the question. So basically the amount of money that we're looking at in that grant was about $8.8 million. So there's a commitment from the administration to be able to match that. It's going to have to come in an amendment to the budget in the near future. So it'll be the same amount. The source of funding will be different. So instead of being a federal source, it'll be a state source. It gives us an opportunity to streamline be a bit more efficient with those funds as a state. And so we're just basically bringing that in-house. But that should be coming as an amendment to the budget in the near future.
Chairman Faison?
Along with that budget, which would come through this committee, by the way, is there a plan that will be made to Tennessee what this budget appropriation will do? Is there something like that we'll know exactly how it's going to roll out, and is it going to mirror somewhat what we were doing? How's it going to engage the local communities?
Yeah, so a lot of the detail, thank you for the question as well. So a lot of the details of that I think is being worked on now. We're engaging a lot of our current stakeholders, people that have done really been tremendous partners in this space to help. I think it's also important, and a lot of times I think people will look at a headline in the press and may not read a lot of details in the article. They think this is affecting treatment of HIV. That's a separate program, a Ryan White program. So people that actually have HIV that are requiring treatment, that program is continuing as is. This is more for the prevention, surveillance, and a lot of education, front end of things. And so there's a lot of work that's being done on that front. But we're engaging a lot of those stakeholders now. We've had a long off ramp for this so that we would have an opportunity to talk to a lot of those individuals in a lot of those groups. And so those discussions are happening now. So I don't want to get too far ahead as far as how that's going to look, but those talks are happening now.
Just a word along those lines. A number of us have organizations in our districts that are doing yeoman's work in this area, and they're saving a lot of cost to the state because of the work that they're doing in preventative care, HIV, hepatitis, all those sorts of things. So it's critical to those organizations. They're planning their budgets. They're trying to figure out how and if they're going to be able to continue their work. So we need to know as quickly as possible where that funding is coming from and if it's going to be in the same amount. All of these are questions, and I know that there's a commitment to continue this through May, but May's not as long away as it used to be, and we really need some direction as soon as possible on those monies to be able to reassure them that they're not going to have to cut programming. And if they do, then I think we all have to recognize there will be a price to pay for that down the road in a whole lot of social ways, as well as financial ways. So just the hurrier you could go on that, the more appreciative we would be.
Absolutely.
Next on the list is Representative Parkinson.
Thank you, Madam Chair Lady. And I want to, I got a couple of questions, but I want to piggyback off of that. I'm trying to understand, get a better, clearer understanding rather of why we would forego that federal money and use state money when they're giving us federal money.
Again, it's a streamlined operations to be able to go from the traditional method of how those are done. We can, I think, modernize it, streamline it, be able to get more of those funds down to the level where it actually helps with prevention and to use what it's originally designed to do.
And
Representative Parkinson.
Thank you, Madam Chair. And with the I guess it was $8 million from the federal government, were we not able to prevent HIV with that money?
Presumably, yes. We'd be able to help prevent it. I think we'd be able to reach more people, I think, by bringing it in-house, because again, you're going to streamline operations and make sure more of those funds get down to those actual programs.
Okay, thank you. The minority health, is there a set budget for minority health disparities for that group under the Department of Health, rather?
Yes, let me get to that. There is, yes, funding allocated towards a lot of that. We have, historically, I think we've got, I believe it's under the Community of Medical Services. We traditionally have about $131.8 million. It's going to provide support for healthcare safety net, Office of Rural Health, departmental efforts in reducing health disparities statewide. And that's an amount that's, it's a budget amount for this is larger than normal, as the department basically is utilizing this code for the distribution of large portions of ARPA funding as well. So we do have monies that are being used in that capacity to help reduce healthcare disparities. We've got an entire department that's dedicated towards that. Maybe you can provide a bit more detail.
Yeah, Representative Parkinson, we use funding from the Health Access Incentive Fund. The Office of Minority Health has probably about a $1.3 million budget, and that's really a staff-only budget. They work a lot with our health disparities group. They work a lot with our rural health group. And so as Commissioner was describing, they're all in one giant organization to help reach out and try to eliminate health disparities statewide.
Is there a reason that they don't have a full, line item budget for dollars that they can operate with to actually eradicate some of the disparities? And it seems like, we're paying for staff, but there's no real intent, in regards to that portion, that part of the organization, because they don't have the dollars to operate directly with. How does that work? Do they just come to you every time they need to do something and say, hey?
Sure. And when I say staff, I mean, they do a lot of operational work. I mean, campaigns, outreach, they do those types of things within that budget. We've been very fortunate with some of the COVID money that's come through, some of the ARPA money that's come through that has really focused on eliminating health disparities. So we've got the infrastructure, we've got the staff in place. It's these federal sources that have helped kind of springboard a lot of their efforts in recent years.
Okay, and last question. Is there any effort to push a state compact when it comes to the shared use of Regional 1?
I'm not aware of a state compact for shared use of Regional 1.
And,
we can look into that, but I'm not aware of that.
And the reason why I'm asking is because Regional 1, of course, is our safety net hospital in Shelby County, but it's not being used only by those that are in Shelby County and Tennessee. We're surrounded by 3 states, and that where trauma victims are flown to Regional 1. But is there, and if not, why has there not been an effort to ensure that these other states that are using our safety net hospital are not paying their fair share for their patients that come in?
Sure. If you give us an opportunity to kind of research that a little bit, we'd be happy to get back to you on that.
Okay. Thank you. Thank you, Madam Chair.
And while you're researching, you can include Erlanger and in
Yes, ma'am.
Chattanooga, we have the same issue with lots of patients coming in from Georgia and Alabama and
Sure.
North Carolina. And not all of those are paying patients.
Yes,
So,
ma'am. We can do that.
It's always been an issue, I think, for us in border cities. And Representative Garrett, I overlooked you on my list, and I offer you my humblest apologies for doing so.
I wouldn't have minded if you skipped me, Madam Chair, but I'll go ahead. Thank you for that. My question refers to a very important piece of some of our programs regarding the healthcare safety net. And so your proposed budget includes $5 million of recurring money for the healthcare safety net, along with $2 million recurring to improve the quality of patient care and create measurable clinic outcomes under the healthcare safety net. The Department of Health has had repeat audit findings that are concerning. Some of the quotes, and then I'll have you all respond to those if you can. Part of the audit says the program annual report contains unsupported data to validate program results. That was in September of 2022. Management did not require service providers to submit documentation to support provider reimbursements. That was from October 2018. Management did not assess the provider payment process for any potential risk of errors, waste, abuse, fiscal and operational risk, and noncompliance with state statute. That's from September 2022. So what I would like for you all to respond is, have these audit findings been addressed? If so, how? Then how can we as the legislature be confident that the new funding for the safety net program, including in your proposed budget, will be spent towards the purposes for which it was awarded, and the program results are being accurately monitored and reported? I know that was a lot, so feel free to take some time to
Thank you for that.
gather
So
your thoughts.
My understanding is that that audit report, that there was, we were in concurrence with a lot of the findings that were made in that, and that a lot of efforts were being made as that report was being issued. There was already efforts being made to correct a lot of those issues at hand. But I'm going to, again, as this preceded my time here, I'm going to let Deputy Commissioner address that.
Yeah, Representative Garrett, great question, good points. We did concur with the findings in the audit. We have set forth some implementation. We've implemented some remedies to help eliminate this. One of our problems was, during the pandemic, we were not making as many site visits as we needed to do. Obviously, I'm not sure that that was the only reason we didn't make the site visits we needed to make, but that is one major thing that we're going to do, or that we've already started doing, is to go on site to verify these records, verify the payments were made in the correct manner. Do you have anything else?
Representative Garrett, in addition to that, we've had the opportunity to really upgrade some of the tracking systems for the safety net partners that are pulling the on-site visits with the additional tracking requirements. We anticipate really having the opportunity to partner with our safety nets and make these services both more efficient and more valuable to the citizens of Tennessee.
Representative Garrett.
Thank you. Thank you, Madam Chair. So as we sit here today, are you all confident that these can be monitored for us in the future so we don't have audit findings like this for the past 3 years?
Yes, sir, we are.
Okay. And then finally, you mentioned you've gone back, but I want to make sure that for the providers that seem to be an issue, have you all gone back to appropriately monitor those providers for the time periods that the audits have found them to be inadequate? Have y'all gone back and figured out why that's the case with these particular providers?
Representative Garrett, we have a system, we call it Red Cap, but that's what we were using to monitor these folks. And part of the problem was people weren't entering the data correctly. So that's something that we will go back and we'll make sure that we're going back and taking care of those missing records or the lack of reporting that was identified in the audit.
Okay. Thank you very much, Madam Chair. Thank you all for being here.
Representative, Chairman Williams, sorry.
Thank you. Thank you, Commissioner Freer. And Chair Lady, just as a moment of personal privilege, I have some constituents who walked in I'd like to recognize. In the back of the room, we have Adam Poe. He's the Director of Economic Development for the Highlands Partnership at Cookwood Putnam County Chamber of Commerce. And beside of him is Amy New, who used to be at ECD, most of you. She was the first rural development for rural jobs in Tennessee under Governor Haslam. She is now our CEO and president in her home county of Putnam County. She's the president and CEO there, but she's best known as being the granddaughter of the Senator Charlotte Burke. So hope you guys will make her welcome.
I had the pleasure of working with Amy for a while when we were both working for Governor Haslam in economic development. So always good to see her. Always good to have folks from back home here, particularly watching you, Chairman Williams.
Yes, thank you. Well, she may be to blame. I think she was a mere college student when she worked on my first campaign for city council. So we go way back. So thanks for coming. Commissioner, I did have a follow-up question on vaccines. Just to be clear, would you say we've had a return to our typical vaccine protocol that we're doing prior to COVID, or are we still, do we still have the structure set up? I know we provide vaccines and services to our regional and county Department of Health and stuff like that. The question is that, would you say that things are back to normal prior to March of 2020?
Well, in regards to kind of traditional pediatric vaccines and that sort of
Yes.
thing, we think of childhood. I think we're still below where we'd like to be. We had a drop. They're starting to come back up, but we're still below where we'd like to be. So we're still trying to get those numbers up as high as we can. Obviously, there have been some outbreaks in parts of the country recently with childhood illnesses that were preventable through routine immunizations. But we are on the rebound here. We had a drop, and it's coming back up.
Chairman Williams.
Thank you. I noticed that some of us watched the Super Bowl over the weekend. We were able to see advertisements for certain things. In particular, was vaccine advertisement. I guess, and we see that on TV a lot. Are most of those dollars where we see that those broadcasting television, are most of those dollars federal dollars that we're still receiving And are there any dollars that are state derived dollars through the Department of Health for these PSAs that we're spending on radio or TV as it relates to the COVID vaccine?
Refer to the commissioner for that.
It's all federal,
Okay.
all federal funding.
Thank you very much.
Leader Camper.
Thank you, Madam Chair. Thank you for your presentation. I have a question on your, the questionnaire that you provided to the committee on page 5 and 6. There's several grants around maternal and child health. And if you look at them, there's like one on abstinence education, home visiting, rape prevention, and things like that. We see that the federal government provided X amount of dollars, and then we only use so much, but we're not carrying those balances forward. So we're either reverting the money back to the federal government. Why aren't we using those funds? Are you with me on page, I think 5?
Yes, ma'am.
And there's several of them under maternal and child health
Let
that
me
I'm
see.
concerned about. Like on page 5, you have the sudden death at the top. You have rape prevention
Yes,
there.
ma'am.
On 6, you have home visits, and it's a lot of federal dollars that we're either sending back, not using. Can you explain?
So, some of it is able to be carried forward, Leader Camper. Most of the ones in that right column would be able to be carried forward into the following fiscal year. When you see underspending, a lot of times what we do is we have a grant that we go out. We grant with a third-party organization. Sometimes they don't have enough qualifying expenditures in that particular period. And that happens. And so we do our best to roll it to the following year and then try to play catch up as needed with those organizations.
Leader Camper.
Yes, I understand the point.
Yes, ma'am.
But let's see, 1, 2, 3, 4. The 5 that I mentioned, we're not carrying those balances forward. That's the point I'm making. And I'm curious as to why we're not carrying those balances forward. Are we just sending those funds back, or is the state going to replace it with, our dollars? I'm just trying to get an understand. Some of it is like lead poisoning.
Right. So some of it is just there aren't qualifying expenditures within a time period to claim the federal dollar. When we claim federal funds from these grants, it's $1 spent, $1 drawn down. And sometimes we don't have enough qualifying expenditures based on the award. A lot of those awards are formula based, and we get what we get based on the formula, and we do our best to spend it. It's not our practice to just normally turn it down or revert it back. And we look for every possible way to spend that money.
Okay, thank you.
Yes, ma'am.
And
Leader Camper.
Madam Chair, just one more on your reversion target. It looked like you had a target of maybe 3.5 million, but
Yes, ma'am.
we reverted back 35.6.
Yes, ma'am.
Can you explain that?
So we got a lot of COVID money,
Uh-huh.
and we've been fortunate enough where a lot of that COVID money has allowed us not to spend state funds that we normally would spend on certain items. And so that's where that huge reversion comes in. It's really a federal over collection of revenue that provides state savings at the end of the year.
Thank you. I appreciate it.
Yes, ma'am.
Thank you, Madam Chair.
Representative Lynn.
Thank you, Madam Chairman. Commissioner, thank you for being with us here today. I appreciate your presentation. It was very good. I have a question from my constituents. The CDC has recently revised their medical codes to track unvaccinated people, and this seems a little odd. Are our electronic health records tracking that too? A doctor puts that in, and can you speak to the purpose? Have you heard anything about why the CDC would do this? I can see tracking illness and other things, but why track the unvaccinated? It causes angst for our constituents to read that. I was sent an article from the Epoch Times about that, and I can give you the article with footnotes if you like.
Yeah, I'm not aware of what the CDC is doing in terms. I haven't heard that as far as them tracking people that haven't been vaccinated. Obviously, if you document vaccinations in medical records, you can, if someone wants to open up, someone is allowed to open up someone's medical record, you can see if they're vaccinated or not. I don't know that we're doing any particular work within the Department of Health to track people that are not vaccinated. I think if someone is and it's documented and someone's received it, we document it in their record. That's the extent of what we do. But we're not doing anything to track people that are unvaccinated.
Representative Shaw, this will be our final question as we're running a bit over time.
Thank you, Madam Chair. Thank you. I'll be brief. Couple of real quick questions. Question number one, how many people, if you know how many people passed on in the state of Tennessee for not getting vaccines? Do y'all have that information?
I don't have that information. That would be difficult to assess, I would think. But I'm not aware that we have that information.
I want to just piggyback on something Chairman Williams asked a while ago about the dollars, federal versus state. Why would the state not provide that information to its citizens about educating people on vaccines?
I'm not sure I understand your question. You say why would we not?
Well, the question was asked a while ago from Chairman Williams, were most of these dollars spent state or federal? And you said federal. And I asked you just reverse that question. Why would the state not spend money to educate its citizens about getting vaccines?
I believe that we've been educating people on vaccinations through the entire pandemic. So that's part of what we're doing. I don't know that we're allocating specific funds particularly for that, but there are funds that have been provided by the federal government to do that for us. And we've been, I think, throughout the entire pandemic, the department's been pretty adamant about recommending vaccinations for people for COVID treatment and to prevent COVID and to help mitigate the effects of COVID.
Thank you. And I think that I neglected to welcome you to the state and to your new role. We just got right into it because that's what we do in this committee. And you survived your budget hearing in finance. So congratulations. And hopefully we weren't.
Thank you, Madam Chair. I try to follow.
Traumatic.
I try to follow instructions implicitly. I've run a committee myself in the past. So when I've been told I've got so many minutes, I try to meet that standard as much as I can. But thank you very much. Appreciate it.
And as a follow-up, I don't want to beat this dead horse, but I know that Chairman Faison and I and some others are really interested in the issue that we spoke about earlier. And I heard you say that hopefully by funding this through the state versus taking down the federal funds, that we may be able to actually get more monies into the programs. And I'd just be real interested in seeing some numbers on how much the administrative costs have been that have been associated with the $8+ million we've been getting, and how those additional funds, if there are to be any, will be allocated around the state. So if you could just provide that, and I'll be happy to share it with committee members.
I'll try to do that. Thank you.
Thank you. We are now going to welcome our TennCare folks to the podium. Larry Miller. All right, Director Smith, as we already have people who are wanting to be on the list for questions even before you started presenting. So to say that there's a lot of interest in what you're going to tell us, I believe would be an understatement. So we will let you get started.
Thank you very much, Madam Chairman and members. It's a privilege to be with you all this afternoon. My name is Stephen Smith. I serve as the TennCare Director. With me today to my right is Zane Seals, our Chief Financial Officer, and to my left, Dr. Victor Wu, our Chief Medical Officer, and to his left, Kim Hagan, our Director of Member Services. Madam Chairman and committee, about a year ago today, I sat before you at the same spot, and I expressed my optimism about both the present and the future of TennCare. And today I can say without hesitation that that optimism is greater than it has ever been. And that's because of the leadership and support of our governor, this General Assembly, this committee, the men and women who have made TennCare their work home, and the tireless efforts of our partners and providers who wake up every day to serve our state and the citizens who rely on TennCare for assistance. I know we are pressed for time, so I'm going to move through this quickly. But if you hear nothing else from me today, I hope that you will hear and I hope that you will see this. TennCare has never been in a more successful position than it is right now at this point in time. And perhaps the greatest evidence of this success is the negotiation and implementation of our TennCare 3 waiver and the shared savings reward that the governor announced in his State of the State address. And that really is the culmination of more than 2 decades of hard work, trial and error, restraint, innovation, and partnership between multiple administrations and multiple General Assemblies. And we remain very thankful for that continued partnership, because the reality is just because we've gotten to this point of success doesn't mean that we are guaranteed to stay here. I want to lead with our TennCare 3 waiver because it really is so essential to the recent improvements that we have made and the items that we are proposing in this budget. We've been operating under this waiver now for about 2 years. And as a reminder, the core principle of this agreement is that we have the opportunity to be rewarded for our sound management of our Medicaid program through additional federal dollars that we call shared savings. And then we will reinvest those funds back into the program through benefits and services and to serve more people in need. Since the implementation of this waiver, we have made unprecedented investments. We've enhanced benefits and services, and we have added more people. Examples of this include a comprehensive dental program for adults for the first time in our state's history. We are serving thousands of additional people with intellectual and developmental disabilities. We're providing 12 months of postpartum coverage to mothers through a pilot program. We have made workforce investments in key areas, and we have provided additional supports for our public hospitals. And we were able to make all of these investments because of our confidence to be successful under the provisions of the waiver. We essentially bet on ourselves, but we did so through strong negotiation and a commitment to agree to a deal only if it would be good for Tennessee and the people that we serve. A deal that, coupled with our efforts, has now resulted in a first-year shared savings of more than $300 million that we are now proposing to do exactly what we said we were going to do. And that is enhance benefits and, yes, expand coverage to more people in need. And here's the kicker. Having these shared savings allows us to do this and to do these things without any additional burden on the Tennessee taxpayer. Today, I'm really excited to outline the components of the governor's Strong Families Initiative, which we will fund through our first year shared savings beginning in FY24. And that will extend through the completion of our waiver, which is calendar year 2030. This initiative includes a permanent extension of the postpartum coverage that I mentioned earlier. Also, we will provide lactation supports for new mothers. We are proposing to increase the eligibility for pregnant women. We are proposing to ensure 12 months of continuous coverage for children. And then we are also proposing to increase the eligibility for parents, closing the coverage gap for between Medicaid and then the federal marketplace. All told, these provisions will add nearly 25,000 additional children, women, and parents to the TennCare program. I do want to point out here that these items are funded on a recurring budget in the budget that you had before you. They're funded on a recurring basis in the budget you had before you, but they will be bought back with the shared savings dollars through calendar year 2030. This will avoid a fiscal cliff in the future. It will continue our practice of conservative and responsible budgeting, as we just can't predict what the world will look like in 2030, although we're very hopeful that CMS at the federal level will see the value of these shared savings and will extend that beyond 2030. In addition, in the forthcoming budget amendment, as the governor noted, we intend to provide for a pilot program where we will relieve a substantial burden of the cost of diapers for babies that are under 2 years of age, which, if approved, would make Tennessee the first Medicaid program in the country to provide this benefit. The intent here is to cover half of a month's supply per child and to fund that on a non-recurring basis through the course of the waiver, which again is 2030. All of these investments are made possible by the TennCare 3 waiver and the resulting shared savings, and they really confirm the collective sound decision-making of our state regarding our Medicaid program over the course of the last 2 decades. And that's really the beauty of this budget and what is possible in the future. While these investments are exciting and they're unprecedented, we will have the opportunity, you will have the opportunity to do so much more. Before I wrap up my prepared comments, I want to be sure to note a few of the other items. First, we have another big investment to support wage increases for our frontline direct service professionals that are working in our home and community-based service programs. That's item number 7. We have another significant improvement for our behavioral health mobile crisis providers. That is item number 6. And both of these will build on investments that you all approved last year. And then lastly, I want to point out that trend number, which represents the cost of doing business. That's inflation, it's utilization, it's membership. And I'll couple that with the pharmacy item because that's really trend as well. So that's item 2 and item 3. Trend is historically the largest item in our budget. This year, it is larger than it has been in recent years. That's not surprising considering we are experiencing really high inflation. And I know you all are hearing from providers, and we are hearing from providers as well about the challenges and just the cost of operating, particularly the cost of hiring and retaining a workforce. Now, you may look at that trend number and your first reaction may be that it's a little low. It's about 2.4%. I thought the same thing when I first saw that, but we have to take into account that utilization is still below where it was pre-pandemic. So we haven't returned to that level. So inflation is partially being offset by the fact that utilization is still it hasn't risen back. So the impact of inflation, it's real. And when we talk about rate increases for our providers, these are the dollars from which those increases will come. The point being is that you don't have to see a particular line item for rate increases for those to occur. And typically you won't see those as we address those through the managed care process and the demands of the market. Madam Chairman, that completes my prepared remarks. I know that was very quick, but we're happy to address any questions or concerns that you all have.
Thank you. As I said, we do have a number of questioners. I'm going to take personal privilege and start out. TennCare is a very complex organization. It's a complex process. Can you just describe for us the different sources of revenue? Where does TennCare get the funds that it disperses for those who participate in the program?
Sure, glad to. I'll take a stab at it, and then I'll turn it over to our CFO, Zane, over here. So Medicaid is a state and federal partnership. So we roughly get 2/3 of our funding from the federal government. We get a 2/3 match, rounded. We also have some sources of funding through 3 assessments. We have a hospital assessment, we have a nursing home assessment, and we have an EMS assessment, with emergency management. And Zane, anything to add there?
We also have some intergovernmental transfers. Those are much smaller than those other 2 mentioned categories.
Have you seen, like the primary sources of this revenue have grown? You have new opportunities. We have the waiver that is going to give us an opportunity to reinvest $300 million. Have we considered reducing our reliance on any of these assessments that you just mentioned, which, if history serves me correctly, if I'm going back and reading my history correctly, they were initiated to be short-term answers to a funding problem that the state had a number of years ago. We've become very reliant on those, and those have grown every year. So are we looking at giving any of these providers that have, voluntarily helped us with these assessments any relief in this budget or future budgets?
Thank you for the question. We have not considered using the shared savings dollars for that purpose, and the reason for that is because those are non-recurring dollars, and I believe that for a conversation around the assessments, we really need to be looking at recurring dollars. Um, Aside from that, I want to go back to the trend number that I talked about earlier. That really represents about a 5.5% trend, which is higher than we would typically see, significantly higher. And so what that will mean is those dollars will actually translate into provider rate increases. Now, granted, it won't be across the board, but that will be handled through negotiations between the managed care organizations and the providers. I do think it's certainly a worthy conversation to have long term about the assessments. But for the reasons I mentioned earlier, we didn't consider using shared savings for that purpose. And the other reason for that is we committed to use the shared savings for new benefits or services or to serve additional people. And so if we use those funds to essentially buy back the assessment dollars, it wouldn't meet that criteria.
But I believe in the beginning of your presentation, and we're all grateful for this, you made mention of the fact that TennCare is in the best position that it's ever been in. And I think part of the reason that we're in that position is on the backs, frankly, of our providers, and their costs have grown. There was an article in my newspaper on Sunday that referenced a study showing that there are 45 hospitals in Tennessee that are at risk of closing. We know a number of hospitals have already closed. And those hospitals, nursing homes, they're all facing the same issues with staffing shortages and high cost of salaries and all of these sorts of things. So whether it's from the $300 million or from other sources, I just think that it's time that we begin to wean ourselves, if we can, from that support level. And if not, at least on a temporary basis, step in to help the funders that have kept us whole through these since 2010. And it's just something that I think providers, it's a serious, real risk with hospitals closing. And, at the end of the day, we talk about the healthcare that TennCare provides, but TennCare doesn't provide healthcare. Our providers do that. And so if we don't have providers out there in partnership, then we're not going to be able to serve Tennesseans. So that's my soapbox for the day. We may come back to some of that, but I have a long list of other questioners. So I will defer. Chairman Baum, you're next.
Thank you, Madam Chair. We've discussed already a little bit about how hospitals are facing financial pressures, and some hospitals are wanting to negotiate higher rates with MCOs. Could you tell us a little bit more about the hospital assessment and whether the hospital assessment is limiting the ability of hospitals to negotiate higher rates?
Thank you for the question. I don't believe that the assessment itself is hindering the ability to negotiate rates. Rate negotiation happens all the time. It happens every year. I can tell you between 2018 and 2022, across all MCOs and across all providers, there's been about a 3.5% average increase. And so that kind of goes to my point earlier where I want to just reiterate that just because you don't see a line item in the budget for a particular rate increase for hospitals or for outpatient care or any number of services doesn't mean that rate increases aren't taking place, because they are. If there is a belief or if there's a concern that the assessment itself is preventing rate increases, I'm certainly willing to have a conversation about that.
Okay, thank you.
Chairman Hicks.
Thank you, Chair Lady. I've got a couple questions here, and I guess I'll begin with, during your presentation back during the governor's fall budget hearings, TennCare proposed a cost increase of 9.5 million to take over one item the assessment has been funding that was not one of the original buybacks. Can you explain what that item is paying for today?
Yeah. That item relates to certified public expenditures, and that request was really sort of a part two to what we did last year. So last year we addressed public hospitals, and this year we had broached the idea of addressing the other hospitals, the private hospitals that are contributing a portion of those dollars through the assessment. So that's what those dollars were for.
Okay, and then changing gears just a little bit, talking about the shared savings. I know this is a casting a wide net, but what services are going to be offered? Is behavioral health, will that be included in some of the shared savings? Where are we going to be spending that?
So what we're proposing to do with the first batch of shared savings, and remember, this is just the first year. So the 300 million plus, that represents calendar year 21. And so we acquired over 300 million. And what we're proposing to do is to take that full amount and extend it over the life of the waiver. So starting with fiscal year 24, going all the way through calendar year 2030. And so that would fund the postpartum coverage extension. It would make that permanent. It would expand the eligibility for pregnant women. We would go up to 250% of income. It would fund, expand eligibility for parents and caretakers of children. That would lift the income cap to 100% of poverty. And that's really important because once you hit that 100%, after you hit 100%, you can go to the exchange and you can get a subsidy for coverage through the federal marketplace. And really anyone between 100% and 150% can get a plan with $0 premiums and $0 deductibles. So very affordable. And then it also would provide 1 year continuous coverage for children. So that will address about 10,000 children who typically come off in a given year because a lot of times because of seasonal jobs that their parents have. And then it would also cover the diaper coverage.
Okay. And then talking about the MCOs and the increase that was given to MCOs due to inflation, how does that get back to the providers?
It gets back to them through the contract negotiation. So as they are negotiating with the providers, they will negotiate on rates, and that's how it will flow to the providers.
And then my last question, Madam Chair, if I may. So how do you all ensure that the rates set by MCOs, that they are in line with market and that they're sufficient to ensure quality of care?
Yeah. Well, the main thing that I would say is that from a Medicaid program perspective, we are required to ensure that we have an adequate network, and we charge our MCOs with building that network. And we really let the market work through the managed care process. And so in order to build that network to be able to serve all of our Medicaid members, they have to provide an adequate rate. There also are some actuarial concerns that we have to address. And Zane, you want to maybe talk through that a little bit?
So there's a number of regulatory requirements that involve the setting of our annual capitation rate. So we contract out to an independent group of actuaries. They set our rates every year in accordance with both federal law and regulations and also with actuarial standards of practice. And so they use the base data that comes from the program itself. They factor in things like trend and inflation and program changes. If the legislature's passed any new laws or initiatives that would direct us to invest in a particular area, all of that gets taken into account. And then they will produce a new set of cap rates prospectively for the next year. And so that does take into account, again, the concept of inflation. And those are the dollars that MCOs can really use to negotiate higher rates as necessary with providers.
Okay. All right. Thank you very much. Thank you, Madam Chair.
Chairman Williams.
Thank you, Chair Lady. Thank you, Mr. Smith, for being here today. I did kind of myriad of questions, but I thought I would go back to something Chair Lady Hazelwood mentioned a moment ago that I wanted to get some clarification on. As it relates to assessment fees, whether it's nursing home or hospital assessment fees or those, you were telling her that we couldn't use those 300,000 or $300 million on because it was non-reoccurring money as reoccurring money. How do we expand services with non-reoccurring money, though? Are we not expecting those $330 million to continue every year? Or?
We are. That I appreciate the point. Really, there were two things I was saying there. One, the non-recurring nature, and as you can see in the budget, we're committing the recurring dollars, and then we're buying those back with the shared savings. So you're right. I mean, we could decide to take out the recurring dollars for these items and use those for another purpose. But the second point is we committed to use those shared savings dollars for new services and new benefits or to serve more people. And if we use those funds to buy back assessment dollars, it wouldn't be meeting that criteria.
Right. So under that premise, though, are you not stating that those assessment dollars would be reoccurring, even though technically we have to pass a bill every year, which means they're not reoccurring? I think, one of the things I'm trying to teach my kids, as you are probably your girls, is not to grow expecting a certain lifestyle. Particularly, I think that's kind of a concern of mine because I know the chair lady has been very good about passing these assessment bills, in particular ones. I think she does the hospital assessment fee and the nursing home bill, and someone else does the EMS. I think it's Speaker Johnson, maybe. But I think one of the things that most concerns me is that we did see this as original stopgap back in 2010, and we've become accustomed to this as if it were a recurring dollar. But if something were to happen, they said, no, don't tax us in this way, then we and you and all of us could be in a world of hurt. So just thought it would draw our attention to this body that this is not reoccurring money. So I did want to follow up on another issue, if that's okay, Chair Lady. I'm going to jump around a little bit. Postpartum care, excited about the program last year, grew it by $6.6 million, extended from, I think, 90 days to a year for mothers and children. Great program, love it. Notice that you expanded it this year with another appropriation because last year was non-recurring, one-time money. But I did notice that in your budget documents that there was a reduction of the original $6.6 million by, I think it was $2 million. I think it ended up being 4.6. Can you tell me what the change was there and why it was, and if it didn't cost us as much money, why are we asking for the larger number again? If you could speak to that, that'd be great.
Yeah, glad to. So I'm going to let Dr. Wu answer that directly. The reason for the reduction is we estimated the initial number of women that would be taking advantage of that, and the actual number was lower. So that's why you see a lesser number there.
Okay.
Thanks for the question. My name is Victor Wu, Chief Medical Officer. And there are just two other points just to add to that, as Director Smith mentioned. One is the number of births that we covered from our original projections is a little bit, now that we have updated numbers, a little bit lower than when we originally priced it out. And so we were covering around, roughly 49,000 births on TennCare a few years ago. We're closer to about 42, 43. So there's a percentage of those that have gone down. And then the second one is with a lot of the work that we've done around eligibility, there's actually been a continued and consistent supports for our moms that qualify in another category. And so some of the pregnant moms have been able to have more seamless, no touch or easier transitions to a different category that they were eligible for, but they may not have filled out the correct, paperwork or gone through the original procedures.
Chairman Williams.
Thank you. Just so inferring something from what you said, are you saying that the birth rate among TennCare mothers is decreasing, or there was just a calculation error?
I don't know that the birth rate among TennCare pregnancies are down, just we are covering fewer births as a state.
Okay.
Chairman Williams.
Sorry, Madam, I almost called you Madam Speaker. What a promotion. The chair lady, a question about TennCare reserves, jumping another topic. Of course, when I got here, if you had $500 million in TennCare reserves, you thought you were killing it. By your communication, beginning of your testimony, you're saying it's never been better to be a TennCare, which is great. It's awesome to do that. Of course, we went from $500 million in TennCare reserves to 1.1 billion that you're talking about this year. I guess the question is how much of that growth or how much of that net difference would you say is due to FMAP? Is it 5%? Is it 95%? Or what are your thoughts there?
It's significant. So actually, we project about, I think it's 547 million of that are the dollars that we need to cover the one-time cost from the increased enrollment due to COVID and the federal provision that we have continuous enrollment. So that's about to end, as we've discussed in this committee a couple of weeks ago. So we're going to, over the course of the next 12 months, go through that redetermination process, but our costs are going to continue. And I believe, Zane, it's about 547 million that we projected.
524.
524.
What's a couple of 20 million among friends?
Right. Right. And then the other thing that with the reserve dollars, which is something new this year, is we are committing some of those to some non-recurring expenses that we know we have upcoming, particularly around technology.
Mm-hmm. Okay. One last question.
Last one.
I know you keep saying that, but just to follow up, the $500 million, $500 million, I'm sorry, that you put in because of redetermination, that $500,000 in additional revenues that you put in is really to pay for those services until those people are redetermined and then off of TennCare. Is that correct?
That's right.
Okay, thank you.
And because Chairman Williams asked so many questions, it gave me an opportunity to go back and think of another one on my own. Circling back to, as you might imagine, the assessment issue is kind of top of mind for me and some other folks. But looking specifically, and as has already been mentioned, we have the nursing home assessment, and actually Speaker Johnson carries that one, I believe, and I believe Chairman Reedy carries the EMS one. But the hospital assessment in particular, it was passed in 2010. Like we said earlier, the state was in a crisis and was facing major cuts because of the Great Recession. And it was a voluntary assessment implemented and supposedly on a short-term basis, which, 14 years later, here we are. 13 years later, my math is really bad. But when we're talking about these services here, they're really basic things like inpatient and outpatient services, doctor visits, labs, all of the things that are basic to medical care that without these assessments would have to be cut. So my understanding is that if you actually did cut any of these, you'd have to get approval from CMS to do that. So the hospital assessments have to be, as has been mentioned here, we have to do this every year. It's not we can't count on it. It's a non-recurring funding mechanism that has to be reapproved by the legislature every year, and the hospitals have to agree to it. So how do you communicate with CMS? Do they understand, I guess, that could be a bit of precarious funding? Are they aware of the fact that this is every year a potential for benefit reduction? And what would happen if we told them we were going to reduce it? Would they just tell us to fund it some other way? I mean, just help me understand that.
Yeah. It's a great question. I hope we never have to be in that position to ask them to make those reductions. But to your question, we have to prepare for this every year because we have to prepare for the fact that maybe the assessment doesn't go through for whatever reason. And Zane, you want to walk through that process?
That's right. So every year we prepare internally. If we were to have to implement these cuts, it would require an amendment to our 1115 waiver. And so we have to prepare a kind of a draft internally that would be ready if the hospital assessment didn't pass. At that point, we would have to submit that to CMS, and then it would go through the normal approval process that any waiver amendment goes through. We've never had to submit that to CMS because the assessment has always passed, but we do have to internally prepare for that circumstance.
And I would assume that CMS approval would not be just an automatic.
All CMS approvals are a very lengthy process. So it would, I imagine, not having done it before, I imagine it would require some back and forth with CMS.
And during that back and forth, what happens if you don't have the money from the assessment? Are you dipping
Essentially,
into your reserves? Is that how you would fund that?
yes, ma'am, we would have to dip into our reserves to fund those.
Thank you. Representative Freeman.
Thank you, Chair Lady. You stated that you received about $330 million in first-year shared savings claims. Are these dollars associated with your designated state investment programs claiming protocol? And if so, are these funds being utilized to fund any programmatic expansions in the 23-24 budget?
Yes, thank you for the question. They are tied to those programs that you just mentioned. However, what we're going to use the dollars for are the items that you see on the screen here. So yes, enhancing benefits and services, and then adding more people, women, children, parents to the program.
Representative Freeman, you have a follow-up?
I do. And do you view these dollars as being non-recurring?
We do. They are non-recurring by their nature. But the way that we've approached it is we've taken the full amount of money, or almost the full amount of money, and we've committed to buy back the recurring funds that are in the budget through calendar year 2030. So because we know we have the dollars to pay for it, for all these things through the course of the waiver. And then we'll get our calendar year 22 shared savings in the near future, hopefully. And then we'll just go every year until 2030. And then this body will be able to make decisions about how to use those dollars, just like these dollars.
Representative Freeman.
Yeah, thank you. I'm going to change topics real quick. I'm looking at a fiscal analysis for House Bill 1215. House Bill 1215 is the one that would limit reimbursements for coverage for gender affirming care. The assessment that you sent shows about a $210 million increase in state expenditures that was accidentally or mistakenly removed or not reflected in the fiscal note. Can you discuss, for the benefit of this body, do you believe that number to be low? And can you discuss exactly what that fiscal impact would look like?
Sure. So as with any bill that comes before the legislature, we are assigned bills through the fiscal review, and then we analyze those bills to the best of our ability to determine what we think the cost would be. We did believe that there would be a fiscal impact on the TennCare program because under our analysis, we just felt like it was very unlikely that we would be able to contract with a managed care organization that would be willing to meet all of those provisions. And so what that would mean then is we would have to, in our opinion, we would have to likely go back to fee for service, which we think would have significant fiscal issues. But we know how the process works. We're just, we're providing our opinion, and sometimes fiscal review accepts that opinion and sometimes it doesn't. And we respect that the official fiscal note is what it is.
Chairman Whitson.
Thank you, Chair Lady Hazelwood. I have two questions, Director Smith. How you doing this afternoon? First question, it has to do with your chart. You talked about some cost increases for 23, 24, and the mobile health, the mobile crisis provider rate increase. Can you explain what that is for, and just a few short details, please?
Sure. So that builds upon an investment last year that you all approved for us, and it goes to the mobile crisis providers. And right now, that's a program that TennCare inherited many years ago. And the way that works is there is a per member per month um, rate that is associated with those services. And so for the first time in many years, we provided that an increase last year. And this year, we're going to do that again. We've had some good conversations with the TAMHO organization. We're talking through how to best distribute those dollars. I think it's been a very collaborative relationship. But I don't know if that answers your specific question, but it will go to those providers to help them to serve TennCare members that are experiencing crisis situations.
Okay, thank you. And my next question is, last year, a total of 25 million, which with 13.3 million state funding in non-reoccurring funding was appropriated for Medicaid health starts. This year's budget proposes an additional 11.4 million in federal funding for the second year of the pilot program. State matching funds for this item will be allocated from the TennCare reserves. How many years is this project or this pilot program slated to last?
Yes, thank you for the question. It's a program that we're really excited about. As you mentioned, we are funding the state portion for that in this next fiscal year through our reserves. It's a 5-year pilot, and so next year will be year 2. We're a little behind because the closed loop referral system is part of that, and we went through a procurement. There was a protest. We had to reprocure, so we're in the middle of that now.
Okay, and how much of the 1-year funding was actually used? Do you know? And if you don't have it available, you can let us know later.
We're still in the middle of, because this fiscal year is the current year. So we've spent several $1 million already. I'll have to get you the exact number after this committee. I can send you the exact number spent to date so far.
And one last question, Commissioner. What were the results of this program? Does the agency anticipate permanently funding this program in the future after 5 years?
Well, we don't know the results yet because this is the first year, and that started July 1. So we just got the funding, and so we're just now getting started. Our hope is that it will prove to be very successful, and at that time we'll be able to either come to you all to have discussions about additional funding, or we believe that if it's deemed to be really successful, that we could work with our managed care organizations to absorb some of the costs because it's proven to improve health, which then drives down healthcare costs.
Thank you, Chair Lady. Thank you.
Representative Barrett.
Thank you, Madam Chair. I'll try to make this brief so I do not hold any of my fellow members from getting to the fish fry. On item 17 on your cost increases is showing a non-recurring increase of a little over 57 million. And that, as I understand it, is for the development operation of the new eligibility system. So 2 questions related to that. As we're getting ready to begin that redetermination process, I think roughly 1.8 million Tennesseans, what role does the TennCare Connect program play in that? And then also, how many TennCare enrollees are currently on that TennCare Connect program?
Yeah. Thank you for the question. It plays a massive role, and the best person to speak to this would be Kim, who oversees all of that. So I'm gonna defer to her.
Hi, Kim Hagan, Director of Member Services. So TennCare Connect is the name of our public-facing self-service portal that any member or applicant can use, 24/7, go in and apply, or update their information, or submit requested verifications if they're in the middle of a review process. And then they'll also be able to use it to renew their eligibility. It is an arm of the brains is called TEDS, which is what the state staff use to make eligibility determinations. And then TennCare Connect is, like I said, that public facing portal that then feeds into TEDS, the state system. And so we hope that a large portion of our members will choose to use TennCare Connect. But there will also be other modalities available to get through the renewal process. They could call our call center, renew that way. They could mail, they could fax, they could go to any DHS office and drop off their information.
Representative Barrett.
So the second part of my question was, how do you know how many people are currently using the system?
Representative Gant.
Thank you, Madam Chair. In last year's budget, when passed, included provider rate increases for community mental centers. And to date, they have received, the one in my district is saying that they have received very little of those retro payments that were to help with the workforce shortage. Can you expand on that?
I may defer to Dr. Wu here. I know that we had to get approval through CMS on those, and so there was some delay there, but all those are retroactive, and so I think those are starting. I think those are starting to move. But
Great. Thank you for the question, Representative. As Director Smith mentioned, the dollars were appropriated and they begin in July of this past year. And then because of the way that our federal authority works, we had to receive full approval for our proposed plan. And there were a couple of different ways that we were going to get the dollars out to the CMHCs, the community mental health centers. And so we received that approval at the very end of 2022 last year, which is great. CMS approved our proposal. And so the dollars that have gone out so far were retroactively dated back to the July period. And then going forward from here on out, every time a new service is provided by the community mental health center for those, for the rate increases, they'll be receiving a higher rate. So we do hope that they've at least seen some of the dollars that are representative of the services they delivered between July and November. And then around December, January, the new rates have been coming in. And so the more services they're providing, the higher rates they'll be receiving.
Okay. Thank you, Madam Chair.
Representative Miller.
Thank you, Madam Chair Lady. Director Smith, team, thank you all. 2 slides, several questions, starting with slide 5. And I'm trying to understand better that in January 20th, we were at 1.4 million. Looks like 22 January, May, we're at maybe between 1.6, 1.7 million enrollees. What are the number of enrollees today, total?
we are at about 1.75 today. So that's about a 23% increase over from March of 2020.
And by September 25th, we're looking at a reduction of, what is that, 200,000 to 300,000?
Well, we don't know. We don't know for certain. We have to go through the process, and so it's all going to be dependent upon who is actually still eligible for Medicaid and for TennCare. We were asked to give our best projection, and so our best projection is that when it's all said and done, we'll be back to where we were pre-pandemic, which is about 1.4.
Now, from a budgetary standpoint, based on what I'm looking at here, your projections of the enrollees, monetarily, what would that amount to? Dollars? Or
So our estimates are that to meet the increased cost as we go through this process, that goes back to the 524 million will be our cost to meet the increased cost from the enrollment, and it'll be non-recurring, of course.
Of course, okay. Thank you for that. Now to slide 4, nearly 25,000 additional children. You're going to expand eligibility for pregnant women, and a specific question in reference to Memphis Shelby County. Can you tell me the let's say, the amount of maternity deliveries in Memphis, Shelby County?
Representative, I don't have those numbers. We can work with
Okay.
with you to get you those numbers.
And how are we taking care of those mothers? What facilities do most of the deliveries? And are those facilities within the network? I mean, if you don't have an answer for that now, could you get that?
We'll be glad to.
me
Yeah, we have a strong network of Memphis providers, Shelby County providers, but we'll definitely get that to you.
Okay, thank you. Thank you, Madam Chair.
Leader Camper.
Thank you, Madam Chair. Thank you, Commissioner, for your presentation. I want to go back to a question Chairman Hicks had around rate increases. And I think you said on an annual basis, you all review rates and come up with what the rate is going to be. Do you have information on how Tennessee compared to other states, particularly the 8 that surround us in terms of our rates and their rates? And then secondly, is it possible that you can provide to the chair and the committee like a broad view of how our rates have been over the last 5 to 10 years? Have they went up? Have they went down? Have they stayed steady? Do you have that kind of information available that you can provide?
Well, I appreciate the question. That is challenging because the rate information is proprietary, and so I don't have a comparison with other states. What I can tell you is, I cited the example between 2018 and 2021 across all MCOs and providers, we saw about a 3.5%. And then there are certain situations where we have instituted across the board rates. There are some rates that we set. For example, the direct service providers for the home and community-based services, that's something that we set. That's not handled through managed care. We made the increase for dental providers last year. We did the behavioral health mobile crisis that you see in this year's budget. So we have had some pretty substantial increases in those areas. But I can't give you specific rates because those are proprietary. And I also want to point out, TennCare does not set the rates. We contract with our managed care organizations and we charge them with building the network and negotiating the rates with providers. And that's worked pretty well for Tennessee when we look at where we've been and where we are today. When I talk about our position of success, a big part of that is through our efforts with our managed care organizations. We've made all the mistakes that you can make as a Medicaid program, and we're in a really solid position now because we've kind of learned from those mistakes.
Leader Camper.
Thank you. Are you able to talk about rates that are within network and that's not within network, particularly around this maternal health in women and pregnancy? I was a little disturbed earlier when I saw that the Department of Health was, sending money back because they couldn't find, people to provide these services. So it just seemed like there's a lot of concern around mental health. I know the governor is putting funds in the budget for pregnancy centers and things like that. So with respect to deliveries, if I, go to a hospital, I'm about to deliver now, and I show up. I don't know about a network. I don't understand. How would that work in terms of the rate of the rate that's paid for being out of network?
Yeah.
And once I'm there, if the hospital see that you're not in network, could they turn me away, or how would that work? What do you see happening in that situation?
Yeah. Certainly, if it's an emergency situation, they cannot turn anyone away.
Okay.
If it's an out-of-network situation, it would be a lower rate. And Zane, do you have that information, or Victor, do you have it?
Typically around 80% of the other contracted rate, but I think that can vary some. Those are negotiated just like the in-network rates.
And that, sorry,
Oh, yes,
just to
sir.
say that, those costs wouldn't be passed on to the TennCare member in any way if they did happen to deliver out of network. I think, fundamental to your question, Leader Camper, which is really a very important question is, are our TennCare moms having really strong access to seeing OBGYNs and getting the maternal health services that they need? And I think from that perspective, we have a lot of levers in place to try to ensure that all of our moms can see OBs. It's a really complicated landscape, as I'm sure you know, and anyone who has been following the maternal health conversation across the state. There's a lot of different pieces. Some of it is our TennCare program, but some of it is OBGYNs not practicing in rural areas as much as they were before. Hospitals that used to be birthing centers are closing down around birthing or providing birthing services for a number of reasons, not just for rate reasons. I think from our perspective, we make sure and we monitor very closely that we have enough OBGYNs across all of our 3 MCOs. And that is a little bit to kind of that tension that Director Smith has talked about, that if for some reason there's an area across the state where there isn't enough OBGYN services, the MCOs must go and negotiate and contract and offer, if they needed to, additional incentives to bring those OBs in. We do check that very closely, and we have a good and very strong OB network across the state where there are OBs practicing. And I think that's been very important for us to make sure that we can get those mothers into different places to deliver. And we've had so far some of the work that's been going on in the maternal health space. We've been really excited to see some beginning, leading indicators. We've seen more moms access prenatal care over the last 2 years than they did before. And we've seen moms coming in after delivery accessing care a little bit higher at higher rates than they were prior to 2019. So still a long way to go. We keep thinking about all the different ways we can support our moms to make sure that both the mom and the baby have a healthy start. But I think we're starting to see some areas where we've at least showing some progress.
Leader Camper.
2 more questions, Madam Chair. I'll make them short. You did say that the difference would not be passed on to the TennCare patient. Did I hear you say that?
Correct. Our TennCare members are receiving the full benefit, and it is,
Okay.
The MCO's requirement to make sure that that member receives the care that they should be receiving.
And this is regardless of in or out of network, correct? Is that I hit her?
Yes. Yeah.
Okay.
Correct.
Okay. And my last question, which I just forgot. Isn't that interesting? By George, I'll send you that question.
Leader Camper, I have another question. I know they're excited to hear it. And if you think of yours while I'm talking, then I'm
By
happy to
George.
come back to you.
Oh. I do remember.
We've talked a lot today
10%.
about the hospital assessment. We've talked about a lot of the front end of the human timeline with the pregnancy and babies and supporting all great things. But we have the other end of the spectrum, and we have nursing homes in the state who are just as in a precarious position as the rural hospitals that I mentioned. Their costs have gone up, and it really contributes. All of these things are dependent on each other. So the nursing home issue, they aren't able to staff for beds. That means the hospital can't move people out of the hospital. You have people who actually don't need hospital level care, but I'm told across the state, they have to stay in the hospital because they have nowhere to release them to. They can't be released to go home, and there's no nursing home bed available. Again, because of the staffing cost and all of the inflationary costs, the nursing homes face those just like the other facilities that we've mentioned. And CMS is ending their FMAP enhancement, which helped keep those nursing homes afloat. That's going away. So is there anything in this budget? And if not, what was asked for in this budget in terms of preventing these nursing homes from some of them closing, but from many of them being underutilized just because of the things that I've mentioned?
Yeah, thank you for the question. A couple of things. So I know that the nursing homes are proposing to max out their assessment, which will bring in additional dollars. And the other piece, you asked if there's anything in this budget. There's always something in the budget for nursing homes because nursing homes have an automatic inflator. And so it's based on inflation. And so every year, nursing homes get an adjustment on their rates.
But what did the nursing homes ask for versus what they got?
I believe the nursing homes asked us to match the amount that they would put in to max out the assessment.
All right, again, the nursing homes, I mentioned the hospitals have been doing this since 2010, but the nursing homes have been paying this assessment since 1990, and I think they've been good citizens and good stewards, but they're in a very, as I said, a very precarious position, and I think we're going to have a lot of Tennesseans who are not going to get the care they need, or it's going to cost them a lot more because they have to stay in the hospital than it would if they could move to a nursing home facility. So what would you see if, to make nursing homes, the facilities whole? I know there's an effort. Their funding is based on an old funding base. So I think it's 2019 costs versus 2023 costs. There's a great deal of difference. So is there any thought to, in some way, bridging this gap for the nursing homes and moving up that cost basis so that there's something like reasonable coverage or reimbursement for them?
Thank you for mentioning that. I forgot to mention we are going to be rebasing that. So you're right. It's been a few years since we've done that.
Yeah, so by state rule, those rates get rebased at least once every 3 years. So moving into the next cycle next year, those will be rebased again. It is important to note that in the interim period between rebases, the rates are not stagnant. They do get an automatic inflationary factor every year that's based on a metric called the Nursing Facility Market Basket, which is a national inflationary metric specific to nursing facilities. We anticipate that metric for this July 1st we don't have that because it's not been released yet, but we do anticipate that it's going to be the highest it's ever been. And so that was taken into account when we did our budget projections and formulated our MCO trend number.
All right, again, I'll just reiterate, I think we have been relying on these assessments, and all of them, I believe, were implemented to be short-term. And here we are 20 plus years later on some of them. And I think because we are in a strong position at TennCare, that it's time we relooked at how we're funding some of these services and perhaps helping our providers who've helped us get through really tough times that they're going through right now, as they did for us when the state was in a bad position. Leader Camper, did you remember your question?
I remember. You mentioned the 80%, and you also said that each MCO negotiates separately, and you have 3 of them that you work with. How do you determine this 80%? Is it of the lowest negotiated one? How would we know how that works?
It would be based on the MCO's lowest negotiated rate. So it'd be 80% of that rate.
And so the institution don't know necessarily because it's proprietary. You can't tell them what these rates are, right? So they'll just have to accept whatever that is and trust and verify, of course, that. And why do we do that? Why do we do the lowest one?
Well, because we're trying to incentivize providers to be part of the network. We want to have as broad of network as possible. And so if there's no incentive to be in the network, then it would just put us in a more difficult position in building that network.
Leader Camper, final question.
Okay, yes, thank you. That sounds kind of punitive to me in a sense. I get your incentive philosophy, but each institution has its own mission of what they're trying to accomplish and what they're trying to do. So it may not be in their interest, so to speak, to be within a network. For whatever reasons, that's true. But they still have to serve the TennCare patient because you can't turn them away. And so because they're not in a position where they can turn these patients away, they have to accept this the lowest rate. I just have a problem with that. I think we need to revisit it and talk about it because first off, we don't know what the real rates are because they're proprietary. And you have three, so maybe a middle ground could work, because the patients still, have to be serviced. And so if they are serving these people, I think and I get your incentive, maybe we need to come up with some other way of trying to incentivize versus just like we're just going to pay them the lowest rate possible.
Well, that's why it's so important for us to have a robust, adequate network of providers. And that's why we work so hard through our managed care organizations to have that network. And so this doesn't happen on a widespread basis because we have a strong network.
Okay. Thank you, Madam Chair. And thank you for your patience.
Thank you. And thank you, Director Smith. You all do provide an important service for, millions of Tennesseans literally across the state. I think we're just, it is incumbent on us as legislators to try and make sure that we're doing that in the most economically feasible basis and that we're paying the way from funding sources that are fair and balanced. So thank you again for being here today.
Thank you.
Without objection, we are back in session. And that does complete our calendar for today. But never fear, we get to do it again in the morning beginning at 8 o'clock. So we will have budget hearings tomorrow at 8. See you then. Without objection, we're adjourned.